Greetings of the day. Today we are going to discuss about the adherence to antiretroviral therapy, and this module is intended for a doctor, counselor and other staff working at ART Center. The pictures used in these presentations have been sourced from online material or textbooks for teaching purposes only. By the end of this module, you should be able to define adherence and describe the importance of adherence and consequences of non-adherence. You should be able to identify the potential barriers to start ART. You should be able to identify the barriers to adherence, monitor adherence, and you should be able to discuss the strategies to promote adherence success and strategies to track loss to follow up and re-engage them, and the basic strategies to reinitiate ART in loss to follow-up patients. You should also be able to explain the link between adherence and resilience. To achieve our learning objectives, we shall be discussing about the adherence definition, barriers in adherence and monitoring of adherence, and strategies to improve adherence, tracking loss to follow-up and re-engagement, restarting ART in loss to follow-up patients or the patients returning to the care, resilience. What is adherence? WHO defines adherence as the extent to which a person's behavior taking medications, following a diet, and/or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. In simpler words, adherence is defined as a patient's ability to follow a treatment plan, take medications at prescribed times and frequencies, and follow restrictions regarding food and other medications. Adherence is a problem not only in HIV but in many chronic diseases, and suboptimal adherence to ART will ultimately lead to the failure of primary regimen. In general, non-compliance is interchangeably used with the word non-adherence. However, the two terms are different, and by definition, non-compliance is described as a patient who deliberately refuses to follow a treatment plan, while adherence is the behavior in which a patient unintentionally fails to follow a plan. Now, why is it important to have a patient ready to comply or adherent to the treatment? Because for ART, a high level of sustained adherence is necessary to suppress the viral replication and improve immunological and clinical outcomes, to decrease the risk of developing ARV drug resistance, and to reduce the risk of transmitting HIV. It is not just if a patient is non-adherent, but why. So we should always dig why the patient is not taking the medication. Is there any mental issue or social issues or the issues we are going to discuss in coming slides. The healthcare workers who have been involved in taking care of HIV patients uh, must have encountered these non-adherence issues, especially the ones who are dealing with IV drug users. Factors affecting the adherence can be divided into uh, 5 groups. These factors can be social and economical, healthcare system related, condition related, therapy related, and patient related. For better understanding, we can divide the general barriers into two broad categories: individual factors, which are either related to patient, disease, medications, and social or financial issues, or hospital-related factors. Patient-related factors include forgetting doses, being away from the home, changes in daily routines, especially in a people who have very busy uh, working schedules, low health literacy levels, state of denial, patient is not ready to accept the diagnosis, and he's going to non-medical related specialities to seek treatment or to get his HIV cured. Non-disclosure of HIV status to the family might make him delay his treatment when any family member is around, and then lack of interest or desire to take medications. Whenever a patient is presenting to you with adherence issues, always ask about why he does not want to take or why she does not want to take medications, or it's simply just he forgets the taking of dosage. Disease related factors which contribute to the non adherence include depression due to the current diagnosis of HIV or other illnesses, neurocognitive impairment due to HIV or other co infections, substance abuse, and alcohol abuse. Medication related factors include adverse effects of ART and other medications used for opportunistic infections, complex dosing regimen, increased pill burden, and dietary restrictions. Low socioeconomic conditions and financial factors can one of be the major contributing factors in non-adherence. Patient might not have enough money to visit the long-distance ART centers to pick up his medication. Another neglected issue is a lack of family support and familial conflicts, which also contribute to the non-adherence. Stigmatization is another problem in our society which should be addressed as early as possible and should be minimized. This stigmatization demotivates the patient further and keeps him away from taking medication. Another issue which is faced in Pakistan is due to the language barrier, because Pakistan is a country in which multiple ethnicities are residing as a colony, so there is a chances that the patient visiting to ART center might understand the language which is different from the healthcare worker. In that case, communications and counseling would be very difficult, and the patient might not understand the importance of adherence. So, always ask for a translator if you think that there is a language barrier. Then there are different religious beliefs and cultural beliefs due to which the patient might not come to the ART center. Rather, they can go to the quacks or uh, spiritual healers to get their HIV healed. Factors related to healthcare systems include the frequent visits to healthcare services which are required to receive care and obtain refills, traveling long distances to reach the health services, especially patients who are stage 4 HIV and they are weak and frail. It's very laborious for them to come from the long distances. Bearing the direct and indirect costs of care, lack of clear information on instruction on medication, inadequate counseling and education, limited knowledge on the course of HIV infection and treatment and adverse events, absence of supportive environments for people living with HIV. HIV-related stigma and discrimination has also been seen among the healthcare workers. They may pass derogatory remarks to the patients, they may be judgmental, which leads the patient uh, towards non-adherence. And it halts the building of rapport between a treating physician or counselor and a patient. Then interrupted drug supply and discontinuity of care is also an important factor which can lead to the non-adherence. Non-adherence is never due to a single factor or single reason. Multiple factors play their role in making a patient non-adherent. Along with the journal barriers we already discussed, there are certain specific reasons in a specific category of population which we should address according to the need of that population. Now we are going to discuss the adherence issues in a specific population and the specific reasons for not getting adherence. Starting with children, adherence among children is really a challenging issue. Limited choice of pediatric formulation and bad taste High pill burden or high liquid volume, large pill size all contribute to the non-adherence. Child might get offended due to the dietary restrictions and frequent dosing requirements. Child might have lost the primary caregiver because the cases are usually transmitted to children through mother. So he might have lost the mother or father during this course of illness, and he might not get the required affection and care. Difficulty in swallowing tablets and adverse effects related to the ARV are also the contributing factors. Now, in adolescence, pill burden is one of the major or most common reason for non-adherence, especially if they are treatment experienced. Then in a growing age, stigma and fear of disclosure of disease is high, and child might not want his friends or her friends to know his HIV status. Safety of medication is a concern for them, and if they face any adverse effects and fear of facing adverse effects, because now an adolescent is starting understanding about the disease and the adverse effects, so he might have a lot of questions and concerns. Peer pressure and perceived need to conform is also a contributing factor. Not remembering to take the medications because of busy schedule, inconsistent daily routine, depression, and substance abuse are also the contributing factors related to this age groups. Now, shifting a child from pediatric care to the adolescence or adult care is very difficult in countries like Pakistan, and assuming increased responsibility for their care, which may lead to treatment interruptions because of forgetfulness, inability to navigate the healthcare system, lack of links between adult and pediatric services, and inadequately skilled healthcare providers all contribute to the non adherence in this age group. These issues are very challenging and should be addressed for better compliance and better adherence of medications in adolescents. Successfully treating a child requires the commitment and involvement of a responsible caregiver and commitment from the healthcare worker. Parents and other family members of children living with HIV may themselves be living with HIV, and suboptimal HIV care and treatment for family members could result in suboptimal care for the children. So, issues leading to non-adherence in pregnant females can be due to physiological changes, social issues, and economic changes. Hyperemesis gravidarum can lead to the patient to avoid taking medications, or she might vomit out the medication after taking due to vomitings. Dealing with the diagnosis of HIV infection, especially if the diagnosis is made during the pregnancy, negatively affects the patients and may be a factor of non-adherence. Concerns about HIV and effect of ARTs on the health of fetus, fear of losing a child or delivering an abnormal child due to ART or HIV contribute to the non-compliance. Increased pill burdens and the number of visits to the clinics, because the pregnant female has to visit the antenatal clinics and then the HIV clinics. This increases the physical burden and may lead to the non-adherence. Then fear of disclosure of HIV status in the family and other relatives, long waiting times at clinics, lack of follow-up and transfer to other clinics after delivery, and domestic violence and trauma, though these are not directly related to the factors of pregnancy, but these are the contributing factors in non-adherence. Patients with mental health issues often forget to take their medications, and their poor organization and poor understanding of the disease, treatment plans, and consequences of non adherence all contribute to uh, the worsening of HIV treatment and making it challenging. People who are actively consuming alcohol and other drugs, and the people who are still injecting drugs, have the issues with their memory. They easily forget to take medications, they have poor organization, and they have, according to them, the better use of money, and they would prefer to buy the substance which they are using for abuse rather than visiting the HIV clinics and picking up their pill. Then they have their own time priorities, and HIV clinics are usually working 9 to 5, but these patients uh, do not reach to the HIV clinics in the morning, or they might come to take their pills after 5 p.m. So this is also a contributing factor. Then there are very limited rehabilitation centers available in our country. It has been noted that relapse rate was high in those who do not manage to quit their drugs. Limited number of HIV treatment centers in country, coupled with chaotic lifestyle of these individuals, it is often difficult to manage PWIDs to access HIV treatment. Even once the ART is initiated, there is a high chance that they may show poor adherence and they have a weak follow-up plans, and this may lead to a high risk of developing HIV drug resistance. In this section, we are going to discuss how the adherence should be monitored. So why is it important to know the adherence of a patient to ART? Objective assessment of adherence is mandatory to deliver the effective and efficient treatment and to achieve the goals of ART. When will you assess a patient for adherence? The answer is on every visit. On each visit, you have to ask the patient about the adherence, ensure and support the adherence. Now, how would you assess the adherence is another question. So there is no ideal method which can perfectly assess the adherence of a patient. However, there are combination of approaches which can be used to assess the adherence, which can be used to ensure the adherence based on your human and financial resources available and your capacity and the acceptability of a patient to implement these approaches. There are four methods which can be used to assess the adherence. These methods are recommended to be used in combination because no one method is 100% perfect to assess the non-adherence. So every method has its advantages and disadvantages, which we will be discussing one by one. First method is viral load monitoring. Viral load monitoring is done to diagnose and confirm the treatment response and failure. This is the most objective test to know the adherence of a patient, because if a patient is not taking a medication, and if he is not honest enough to tell you that he is taking the medications or missing the medications, viral load increase can alert you to look for the non-adherent. However, before labeling the patients having non-adherent or treatment failure, you should always look for the other causes like drug stockouts, drug interactions, and malabsorptions. The advantage of this method is that it is the most objective way, and it can pick up the virological failure earlier, even when the clinical signs and symptoms are not visible of failure. The disadvantage of this method is the lack of opportunity for care provider to monitor non-adherence in real time. It is recommended to use this method in combination with other approaches to monitor the adherence. Second method is pharmacy refill records. The pharmacy refill records provide information on when the people living with HIV have picked up their medications. When people obtain pharmacy refill at irregular intervals, this indicates non-adherence to ART and should prompt the further investigation. The disadvantage of this method is that patient might pick up the medication on time and still not using it. This This may lead the healthcare provider to overestimate the adherence if pharmacy refill records are used as a method to assess the adherence. Although this method has been found better in studies as compared to the self-reporting, it is still recommended to use this method in combination with other methods to assess the adherence. Method is self-reporting. Self-reporting is asking the people about their compliance or their caregivers about the number of doses of medication that have been missed since the last visit or within the specified number of days in the past. Always ask about the incorrectly taking doses, timing of the dosages, uh, number of the doses which have been missed, and reason for missing those doses. The disadvantage of this method is that people might not remember the doses they have missed accurately, or they might not want to tell you about the missed doses because they don't want to um, be judged, and they want to be perceived as they are adherent, and they want to avoid the criticism. Counseling plays a very important role in remembering and documenting the ARV drug doses in an environment that promotes and enables the honest reporting of non-adherence. It is recommended to use this method along with different methods to assess the adherence. Fourth method is pill counting. Counting the remaining pills in a bottle may help to assess the adherence. The disadvantage of this method is that patients might throw the pills away before coming to the healthcare facilities. This is time consuming, and due to the limited number of healthcare workers available at ART centers, uh, this would be more resource requiring method, and doctor might overestimate the adherence if the patient has thrown the pill away without taking it. It is not the very reliable method, and it is recommended to use this method with other methods. Here are some questions which can be helpful in assessing the non-adherence through self-reporting method. For example, you can ask, how has it been going taking your medications, or how many doses have you missed in last 30 days? What was going on when you missed your doses? What are the general barriers? What are the reasons or factors which are leading towards the non-adherence? What is the usual time when you take your medication daily? Or do you take your medications daily at the same time? How frequent do you miss your medicines? Similarly, the treatment supporter or a family supporter can be asked whether he is giving the medication under supervision, or how many times he has noticed that patient has missed the doses, and what were the contributing factors. In this section, we will be discussing about the intervention and strategies to improve the adherence. While designing the interventions, the most important step is to understand that every patient is different from other, and every patient has different reason for non-adherence. So the strategies should be planned according to the needs of that patient. One strategy will not work for everyone, and targeted strategies should be incorporated while addressing the adherence issues. Interventions can be applied at individual level or at program level. Interventions which can be implemented at individual level include regimen related, family support related, and provider related. But before implementing these interventions, the first step is to make a good team. Ensuring adherence is not a single man's job. A helpful team based on healthcare provider, counselor, patient himself, and caregiver is required to ensure long-term adherence and good response to ART. A supportive team has always positively influenced the patients with HIV. So before implementing individual level intervention, the first step is the development of adherence plan and education of the patient. Then regimen related interventions include involvement of patient and caretaker in decision making, and the treatment plan should be mutually agreeable to healthcare worker and patients. Counseling and education is very important. All the concerns related to drug adverse effects and adherence of a patient should be addressed. Adherence should be ensured and emphasized, and the consequences of non-adherence should be clearly communicated to the patients and their caregiver. Fixed dose combination should be the priority while designing the regimen, but if due to some reason fixed dose combination cannot be used, then the regimen with minimum pill count should be chosen. Provider related interventions include empathy, non-judgmental attitude, development of communication skills and technical expertise, consistency, continuity of care, and commitment from healthcare workers. Family plays very important role in ensuring the adherence. Family education and counseling should be done at the baseline, and then on frequent intervals or whenever the family member wants to discuss the concerns, they should be addressed and accommodated. Provision of visual and written materials, daily schedules with time and doses of medications, use of syringes, medication cups, or pill boxes can also be helpful in ensuring the adherence. But the most important thing is patient's commitment and willingness. If the patient is not ready to accept the diagnosis, are ready to start the treatment, all the strategies will go in vain. So always ensure before starting ART that patient is understanding the disease, is willing to start the treatment, and is committed towards completing his treatment, and will be visiting the ART center whenever he will be asked to. Program level interventions include mutually acceptable goals, short-term treatment goals planning, early follow-up visit, avoid imposing out-of-pocket payments, preferring fixed dose regimens, strengthening the drug supply management system to avoid stockouts, maintain the continuity of care and continue therapeutic education, and availability of maximum care under one roof. If forgetfulness is the main reason for non-adherence, due to chaotic lifestyle or busy schedule or some other reasons like neurocognitive impairment or mental health issues, this can be solved by sending the reminders in the form of SMS, by setting alarms, by doing phone calls and reassuring that patient is taking medications, maintaining diaries and calendars, and this can be helpful in improving the compliance. Starting ART in PWIDs is very challenging. Careful planning should be done before initiating ART. The readiness of PWID to start treatment and acceptance of the diagnosis is very necessary before starting ART. Adherence should be assessed at baseline and then on every visit. Treatment supporter can be appointed, and this treatment supporter can be from the family or from friends or from some NGO, and the responsibility of this treatment supporter is to ensure uh, that patient has taken ARVs on time and have not missed any dose. Then these patients should be sent to the detoxification centers, and this will help in quitting the drug abuse. Linkages to the NGOs or community-based organizations in ART centers would be helpful in ensuring the adherence, and rehabilitation, especially occupational rehabilitation, will play an important role in ensuring the adherence. Simpler the regimen, better the results when it comes to the children and infants. Medicines are usually not palatable, hence, if not contraindicated, you can add flavoring syrups or intake of food simultaneously with ARVs. Then quantity of liquid and pills should be reduced as much as possible. Reminders can be set. Child can be incentivized. For example, you can promise a child to provide some gift or some other incentive if he remains compliant till his next visit. Family has the most important role while handling the child because children and infants are usually dependent on the family members for their medications. So, vigilant observer and supportive family is very important for to ensure compliance. At the level of healthcare provider, the non-judgmental behavior, rapport building, positive reinforcement, and child-centered approach will be helpful in improving the adherence. So, studies have shown that uncontrolled depressive symptoms are directly related to the low levels of adherence to ART and result in poor treatment outcomes. Several strategies have been designed to target depression and psychological stress to improve adherence to ARV, and these include co-counseling for HIV and depression and appropriate medical therapies for individuals with mental disorders if indicated. Individuals with substance abuse disorders may have poor adherence to ARV. Counseling is very important to ensure that patient remains adherent to the ARV. The objectives of drug adherence counseling are to support the patients in making informed choice on HIV treatment according to the individual needs, assist patients in adopting drug adherence behavior, and enhance patients' ability in managing and maintaining the treatment. The learning theories, adult learning theories are used while designing the education plan and counseling plan of these patients. There has been a very interesting model from Hong Kong which can be helpful in designing the local counseling strategy. Based on this Hong Kong model, the drug adherence counseling can be divided into four stages. The first stage is the stage of general preparation, which is done prior to starting ARVs. And the main objective of this stage is to provide the general knowledge on ARV and assess the readiness of a patient to accept the ARV and briefing about all the side effects and other addressing other concerns of the patient. Then comes the stage of treatment initiation, which is done at the time of initiating ARV, and at this stage, the patient's readiness to start the treatment is assessed and potential side effects are communicated to the patient. Then comes the stage of consolidation, which comes after starting ARVs, and the counseling is done within 3 months of starting ARV, and the main objective of this stage is to perform the overall drug adherence assessment in every clinic visit of a patient. And there are certain other objectives, the details of which can be found on the link given below this algorithm. Then comes the maintenance stage where the patient is stable on ARV, and the objective of this stage is to perform overall drug adherence assessment in every clinic visit of a patient and to identify patients existing or new barriers in case the patient is non-adherent or may become non-adherent due to these barriers. So the details can be found on the link given. So this table summarizes the interventions which can be helpful in improving adherence. This has been taken from the local guidelines. You can refer to those guidelines to review this table and other details. Loss to follow-up is another issue which is encountered by each HIV center, especially while dealing with IV drug users. The risk of loss to follow-up is high. Uh, Tracking them, tracing them, and retaining them in healthcare is really challenging in clinical practice. By definition, a patient for whom 3 consecutive months have been elapsed since their missed appointment or drug pickup are labeled as lost to follow-up. There are certain strategies to track these patients, and these include reviewing logs at the end of each day and noting the names who have missed their appointment today, then making calls to these patients or attendants or treatment supporters and ask them to bring these patients to healthcare, rescheduling the appointment involving NGOs or community-based organizations to help these patients to come to the ARV centers. NGOs can find these patients and their health and can bring back to them to the healthcare facilities. Calls should be made on priority basis to the pregnant females and the ones who have recently been started on ART and children. The outcome of these calls should be recorded, and depending on the number of humans available and the financial resources availability, the number of calls can be decided by each HIV center. Usually, 3 calls are made to the patient for calling them back to the healthcare setup. There has been a study in which different strategies were applied to re-engage patients who lost to follow-up. And this study was conducted in high-income countries, and the methods which were used to identify and contact these patients were with the help of distribution of flyers and brochures, coordination with other services, sending messages and contacting close relatives, home visits and field visits to the last given address, internet searches and or secondary database searches, use of electronic database to confirm the status, post mail, letters or emails, and calling patients by phone. Uh, Few of these options are not viable in Pakistan. For example, use of electronic database to confirm the status because our database is not updated, and many patients provide incorrect information uh, at the time of registration, so they cannot be reached out. Many patients do not have access to the mobile phones or internet and email addresses, so we cannot contact them. However, we can design our own strategies to uh, improve the identification and contacting of these lost to follow up patients depending on our available resources. Generally, the 3 calls are made to the patients to call them back to the healthcare facilities. However, this number can be decided by uh, every HIV center depending on their availability of resources. So, this same study provides a list of strategies which can be implemented for re-engaging these patients into healthcare, and few of them can be adopted in our setup as well. For example, building the staff-patient relationship in enhancing the strength, knowledge and skill building, scheduling, changing and completing a medical appointment, etc. Healthcare worker has a big responsibility and he can be very helpful in re-engaging these patients with the help of its good behavior. So, healthcare worker should refrain from passing derogatory response. He should empathize with patient. He should provide compassionate care. He should be firm but polite, humble. He should be confident and has good grip on knowledge and communication skills. And one-to-one interviews and group discussions, etc., can be more helpful in improving adherence and compliance. The other strategies which we can use in our setup is counseling and education in each visit, implementation of telemedicine, which has been strengthened during the COVID era in Pakistan, engaging the lost to follow-ups and group discussion with other patients who are adherent and discussing the success stories of these patients with them to make them adherent and motivating them. Group activities like painting, singing, etc. can be adopted, and other incentives like monetary benefit, food, or support can be used to re-engage them in health care. Same study further reports that initially the patients who were misclassified as lost to follow up, among them up to 61% of patients were uh, still in HIV care. Many patients transferred to another clinic, few died, and few migrated to other cities. The percentage of re-engagement or return to care was between 7 to 86%, and from 3 to 58% patients refused linkage to the care. The follow-up outcomes of interest were viral suppression at 6 and 12 months, and retained within the care up to 6 months and then 1 year. So up to 90% of patients had viral suppression at 6 months, and up to 82% of patients retained in care uh, for 6 months. The initiation of therapy in these patients is very challenging, and decisions should be taken very carefully. Multiple factors should be considered before starting ART. The decision to start ARV should not be in a hurry, neither it should be too late. Counseling and adherence assessment should be done in each and every visit. Patient may be asked to visit the clinic on weekly basis or fortnightly to see the seriousness and commitment. Treatment buddy can be appointed, and this can be a family member or a friend or someone from the NGO or CPO. There is a high chance that the person who are still injecting drugs will relapse and will stop taking medications again. So, starting ART in these patients is not recommended until the adherence is ensured. These patients should be sent for detoxification in rehabilitation to improve the adherence. It should be clearly communicated to these patients that only the limited number of ARVs are available, and in case of non-adherence, this would be difficult to control their disease with available number of ARVs. In next few slides, we will be discussing about the resilience and its relationship to the HIV treatment adherence. Resilience has been defined by a number of people. However, Corner and Davidson has simplified its definition, and according to them, resilience is the combination of personality characteristics and successful coping that allows an individual to function adaptively in the face of or following the adversity. In simpler words, the capability of a person to come back to life and face the challenges after being through very adverse events in his or her life is resilience. The resilience resources are divided at individual, interpersonal, and community level. However, the discussion of these resources is beyond the scope of this presentation, but these can be found on the references given at the end of this presentation. The effects of resilience has been studied with other chronic diseases. In studies done on HIV patients, it was found that high resilience was associated with higher adherence to the ARV, especially in women. Studies also suggest that women with higher scores of resilience had increased odds of having undetectable viral loads and higher level of adherence to the ARV. Resilience may also be encouraged to get engaged in more health promoting behaviors like eating healthy foods, exercising, and adopting healthy lifestyle behaviors. Tomakoski examined the CD4 cell count as an outcome in a patient with resilience and found that explanatory style optimism was predictive of a decline in CD4 cell count. However, there is the limited research on the subject, and this area needs more research and advancement. And with the help of this research, we can um, improve adherence in our patients. Now, have a quick look on important points we discussed in this module. 95% of adherence is necessary to achieve the goals of ART. Factors related to non-adherence are on individual and hospital level. General barriers and specific barriers according to the patient population should be assessed and addressed. Focused intervention should be adapted to improve adherence. Special attention and care should be given while handling adolescents who are now transiting from pediatric to younger population. Adherence can be improved with simple strategies. Monitoring of adherence can be done through viral load, pill counting, self-reporting, and refill record. It is recommended to use these methods in combination. Loss to follow-up rates are higher in PWIDs, and in such cases, treatment buddy or NGO plays a vital role. Methods to track down and re-engage these loss to follow-up patients should be designed as per need and on individual needs. The strategies to track these patients start with availability of correct demographic information and working number or address. Tested strategies are calling the patient directly or treatment supporters for follow-up, rescheduling appointments, reaching out to community-based services or NGOs to track them at home or their addiction hub and counsel them and convince them to come back to the ART centers. Re-engagement to the center requires education, clearly identifying the barriers and minimizing them as much as possible. Group discussions, group activities, and rehabilitation all work positively. Patients coming after many months should be reassessed for opportunistic infections and WHO staging. Defer the reinitiation of treatment in IV drug users till the adherence is ensured and barriers have been taken care of as much as possible. Resilience is a person's ability to bounce back from adversity and has a positive relationship with HIV adherence. Area needs more acceleration and advancement in Pakistan. So, these strategies can be used to improve treatment adherence, and these include therapeutic patient education, simplifying treatment regimens, minimizing treatment costs, reminder programs, early follow-up visits and short-term treatment goals, and maximizing placebo effects and minimizing nocebo effects. These are the references from which this module has been prepared, and for additional information you can refer to these links.